Dr. Del Castillo graduated from dental school in Venezuela in 1993 and became part of their faculty, where he taught for 3 years before attending Tufts University in Boston in 1996 for a postgraduate program in prosthodontics. He graduated in 1999 and taught at Tufts for 1 year, then went back home in 2000 to work in his dad's office while also teaching at Alma Mater for 2 years. Then Tufts inviting Dr. Del Castillo to return in 2003, where he was teaching and practicing in the US ever since. As a foreign trained dentist, he had to go through the US dental school and was able to get his degree again from Tufts in 2009. Dr. Del Castillo was born in, is it Caracas, Venezuela? I hope I didn't butcher that too bad, Dr. Del Castillo. He's married to Maria Eugenia Gonzalez, who also is a dentist. They have 2 girls, Emiliana, and Victoria, 10 and 9. He was diagnosed with scleroderma in 2014 and received a double lung transplant in 2018. Dr. Del Castillo so far seems to be enjoying everything well. He enjoys mentoring dentists and helping them understand the unique needs of scleroderma patients to successfully treat them in their private practices. And Dr. Del Castillo has agreed to work with me to look at what doctors he might have mentored in our area that have come out this way that now understand scleroderma, and we're going to start sharing that information with our local support groups, which I think is wonderful. And if anybody is interested in other areas, you can send me an email and I will check with Dr. Del Castillo, and perhaps he mentored somebody that is now in your area, and we can help you find somebody that has an understanding of somebody living with scleroderma and their dental needs. So without further ado, I'd like to introduce Dr. Del Castillo, who will be speaking about scleroderma and dentistry. Take it away, Dr. Del Castillo.
Thank you so much, Tina. Thanks for that great introduction. Give me 1 second to share my screen.
Can you repronounce your daughter's name that I butchered so badly, please?
No, you did it perfect. It's Emiliana.
Thank you.
All right, great. Okay, hi everybody. Welcome to this lecture, this presentation on scleroderma and dentistry. My name is Lusi Del Castillo. As Tina just mentioned, she did a great introduction. Thank you so much again, Tina. And I'm a prosthodontist. A prosthodontist is a specialty in dentistry that deals with anything that is prosthetics. So crowns, bridges, dentures, anything to restore the mouth. And I'm currently practicing in Boston and teaching at Tufts University. I wanted to give a special thanks to the Scleroderma Foundation of Southern California for arranging this meeting, and also to Dr. David Leader, who's one of my colleagues at Tufts, and he has lectured extensively about scleroderma and dentistry too. And he graciously shared his material with me so that I could, give this presentation to you today. One disclaimer that I wanted to just mention is that other than my private practice, there have no financial interest or relations with any of the products that I'm going to show you today. And this is where I'm from. This is Caracas, Venezuela. And like Tina mentioned, I graduated from dental school in 1993. I taught in my school for about 3 years before going to Tufts Dental School for the training in prosthodontics. It was a 3-year program. So I finished the program in 1999, and then I stayed 1 more year teaching at the school, and then I went back home. I spent a couple of years home practicing and teaching. And then in December 2002, the school asked me to come back, so I came back in 2003. And I've been here ever since. I got my second dental degree from Tufts in 2009. And now I'm still teaching and I'm practicing in, this is a picture of my practice. It's called Beacon Hill Dental Associates, and it's located in an area called Beacon Hill, which is very close to downtown Boston. If you have been to Boston, you're familiar with Boston, you probably know about Cheers, the sitcom from the 80s. So that's Cheers right there. And I'm actually 4 doors down from Cheers. So if you see the picture here, this black window on the picture, that's my next door neighbor. So I'm actually 4 doors down from Cheers. And Boston has 2 big parks in the middle of downtown, the Boston Common on the Public Garden. My office is right across the street from the Public Garden, so it's very good location. I'm thankful to have a great location for my practice. Over here is Fenway Hall, also known as Quincy Market. Boston Tea Party is right here. And so that's where my practice is located. So now let's get into this. So what does your dentist needs to know about scleroderma? So first, what oral health issues are associated with the disease? For instance, a small mouth opening, which makes us treat you, it makes it a little bit harder for us to treat you. The tightening of the cheeks, we need to rely sometimes on pulling your cheek to the side a little bit to be able to reach in the back of the mouth. When those cheeks tighten, then it makes it a little bit harder for us. Also, there's a big prevalence of decay with this disease, unfortunately. So how much decay can you get in a certain period of time? How aggressive we have to be to treat you? How does scleroderma affect your systemic health? So your dentist needs to know that this disease can affect your lungs, like it did to me, can affect your skin, and can also have GI involvement. So meaning, problems with GERD, with reflux. They need to know also what medications are you taking, because some of those medications that we have to take can affect the flow of saliva in your mouth. And saliva is very important to have in your mouth because it creates a buffer to try to lower the pH of the mouth and reduce the acidity on the mouth and prevent decay that way. So sometimes people can take antidepressant or lung inhalers or heart medications that can restrict the flow of saliva, and that's going to adversely affect your teeth. They need to know also who are your physicians, in case they have any questions about your case and any concerns that they may have in something that they're planning to do. Is that going to affect you medically because of your condition? And now, how can they work with the dental team? So, like I said, they try to learn how to approach the case. What would be the best way to approach the case, your particular case, based on your conditions? And like Tina said initially, this disease can affect people many different ways. Like, for instance, in my case, affected more the lungs than anything else. I have very little skin involvement, but it affected my lungs initially. So they need to know, in your particular case, which organs are more involved, which is the best way to approach your case in terms of dentistry. And also, how does this disease affect or related to dental implants or orthodontic treatments? Actually, there's no contraindications to get dental implants with scleroderma, but dental implants are not for everybody. To be able to get dental implants, you need to have enough bone. And even if you have enough bone, there's certain structures in the mouth that we have to be aware of. And so don't think that when you see advertisements of dental implants that teeth in a day or stuff like that. I mean, those can be done, but it's not for everybody. Every case has to be studied very carefully. And the other thing with dental implants and scleroderma is that even if you have enough bone, we're dealing with very small instruments, very small screws. And if we have a hard time getting all the way to the back of the mouth to place an implant, it's going to be very difficult to restore it too. So it depends on how the disease has progressed in your body and how much oral involvement is because of the disease. But there's no contraindications for dental implants. There are no contraindications for orthodontic treatments for scleroderma. What are the things that happen in the oral health, happen in the mouth with this disease? One of them is Serostomia. Serostomia means dry mouth. And that's usually very common with this disease. One condition that happens too is Sjogren syndrome, and it's an autoimmune disease that affects the glands that produce moisture in the body. So it can affect the lungs, the kidneys, the nervous system, and can create dryness of your mouth and dryness of your eyes too. This disease can also affect your teeth and your bone by creating bone loss around your teeth. So your teeth may start to become loose and eventually come out. Also pain and difficulty opening the mouth because of the tightening of the skin and the cheeks around your mouth. And the sclerodactyly is the tightening of the fingers. So if your fingers are really tightened, then you have a hard time holding a toothbrush, and you have a hard time also maintaining a good oral health in your house. The oral effects of the medications, like we talked about, the effects of the creating dry mouth, that has to be addressed too. Also, the psychological effects of depression and self-image. I have patients that, even myself, there's times that I don't like the way I looked at pictures when I started to see my face change because of the disease. And I have patients that they don't like to have their pictures taken. So that also creates a psychological effect in the person. And even though we're treating the mouth, we also have to consider these things too when we're treating you as well. And one of the big ones is also the reflux, the GERD. And because when your GERD is very active, I cannot put you too far back in the chair. Like a dentist cannot put you too far back in the chair. So you have to work at a certain angle. And the way we work with patients is usually mostly with you laying horizontally, or maybe just slightly elevated. But when the GERD is very active, we cannot put you back so far. So that creates a limitation as well for us, dentists. How do you know if you have a high risk of tooth decay? When you have 3 more cavities in less than 3 years. And with this disease, it's common to have carious lesions rather quickly. When you have teeth missing due to caries. Now, usually when we start losing teeth, we start losing the back teeth first, and then we end up losing the front teeth. And the teeth are shaped and are there for a certain function. The front teeth are there so that you can bite into things, and the back teeth are there so that you can chew. So the moment you start losing your back teeth, then you start using your front teeth for biting and chewing. And the front teeth are not made for chewing. So next thing you know, your front teeth are starting to break down too. So if you don't have your back teeth in your mouth and you have a front tooth that doesn't look very good, we can make the most beautiful crown ever. But if you don't have the support in the back, that crown is going to fail. And this happens not only in scleroderma patients, and any patient. So if we need to have the back teeth to protect the front teeth, and we need the front teeth to protect the back teeth so that the front teeth can bite into things, the back teeth are there for chewing. If you have a severe dry mouth, that can exacerbate the production of cavities, because the primary function of the saliva is to wash away any food debris from your mouth after you eat. And the saliva has enzymes that break down the food and aid in the digestion. So when the saliva doesn't break down the food enough, it can get stuck to your teeth, and then it can create eventually cavities. Same reason that the medication that reduce salivary flow, then, if you don't have slow saliva or low saliva, then you get more prevalence of decay. When you can see the dental plaque on your teeth, a dental plaque is a sticky, colorless film that constantly forms around your teeth when food and fluids combine, and plaque, which has bacteria formed around your teeth. So when you can visibly see it, then there's more of a chance of getting a cavity. Also with the exposed root surfaces, and this happens also again with scleroderma patients and regular patients too, is that with time, the gum starts to recede. And when the gums recede, the enamel, that is the part of the tooth that you can actually see, and the root is down below. So when the gums recede, the root is exposed, and the root doesn't have the protection of the enamel. So it's more prone to get a cavity around the root surface area because of the recession of the gums. And also, you can have a high risk of tooth decay if you have a hard time keeping your oral health keeping a good oral health at home. Now, what can you do to prevent cavities? Well, one thing to do is watch your nutrition. And I'll be interested to see the presentation from the doctor that's going to talk about nutrition. But the idea is to try to prevent, sugary things and sticky food that can get stuck to your teeth, especially if you have a hard time trying to maintain a good oral health at home. Make sure that you get regular cleanings with your dentist too. Sometimes we do cleanings every 6 months. Depending on your case, we may have to do it sooner, every 3 months or every 4 months. And you have to have the hygienist of your dental office and the dentist teach you how to keep your mouth clean. Also, fluoride applications, which are usually done in the office, but we can also prescribe toothpaste which has a high content of fluoride. We're going to talk about it a little further down. And any medications or any type of aids to treat your dry mouth. The treatment of the GERD, that's going to have to be combined with your doctors. And make sure that you have, recurrent follow-up appointments with your dentist to try to keep up with, if you see a cavity that is forming, catch it before it gets any worse. Now, nutrition is a tricky subject because it cannot affect your health as well as your teeth. And like I was mentioning before, if you're missing back teeth, that's going to prevent you from chewing properly. If you cannot chew properly, then you're not digesting properly too. There's no specific diet for scleroderma, but there's some things that we should avoid, especially if we have a very active GERD, which is, anything with caffeine or chocolates or spicy food. Try to don't eat too late at night. Eat at least 2 hours before you go to bed. Try to avoid sugar drinks like sodas and stuff like that, and try to avoid sweets. If you want to have sweets, I suggest that you use any type of sweets that has xylitol in it, which is a sugar-free, and it helps also maintaining the teeth too. And like I was saying before, your ability to chew can affect your nutrition. If you're missing your back teeth and you cannot chew properly, then your nutrition is going to be affected. Make sure, again, to have recurrent hygiene appointments with your dentist. And your dentist needs to get very familiar with your case, as well as the hygienist. The hygienist is a person that's going to be responsible to teaching you how to keep your mouth clean and help you with any type of aids that is going to help you maintain a better oral health at home. And get a good training with them so that you can keep a good, good health, oral health. And the fluoride treatments, we're going to talk about it too, like I said, a little bit ahead, but this is stuff that we can do in the office, and also we can prescribe high content fluoride toothpaste for you to use at home. So in terms of toothbrushes, it depends again on how much the sclerodactyly is affecting you, if you can hold a toothbrush well or not. There are certain aids that can be added to your toothbrush to help you hold it better and maneuver it better. This is another toothbrush, that has thicker handles, so it's a little bit easier to grasp. This is a toothbrush that has 3 sides, so it makes it, you can clean 3 sides of the teeth at once. Another option is the electric toothbrushes or power toothbrushes. I recommend this type. I've tried both of them, and I'm currently using the Sonicare. Whatever you use, it doesn't really matter. I mean, it's whatever works for you, it's fine. These are really good because these vibrate at a very high speed, so it helps you, clean away anything from your teeth. And you don't really have to move it back and forth. You just gently apply it on your teeth and just brush down and let the toothbrush do the work for you. And these have very thick handles, so it'll be easier for you to grab them if you have a lot of hand involvement with the disease. But whatever you pick, it doesn't really matter. I mean, these work really well, so whatever works for you best. Another thing is flossing. Now, flossing can be tricky, especially with hand involvements. If you can manage the regular dental floss with your fingers, that's great. You have these options here that I'm showing you, where it has the handle with a little bit of floss here. This is a power flosser which vibrates and goes up and down, so you can put it around your teeth and between your teeth, and it cleans. This is the same thing as this one, but it has a bigger handle. And this is another one that is angled, same as this type of flosser, but it is angled. I actually have samples here to show you. So this is the angle one. I particularly like this one because this is easier to get in your back teeth, way in the back, and it has sort of like a toothpick on one side, so that you can use it to clean anything that you can see, and then floss all your teeth with this. This is another example, which is like the Dentec you see in the screen, but this is not angled. So I think these are harder to go way in the back of the mouth. I think the angle one is easier to get all the way in the back. But whatever works for you, it's fine. If you can handle the regular floss, great. Or you can use any of these aids here. Another one is a proxy brush. A proxy brush is a tiny little brush that is shaped like a Christmas tree. And it comes, as you see here, like in a handheld, or has a big handle. And the idea of this is to go in between the teeth and clean away anything that you see that is being stuck around your teeth. With this disease, what happens too, like I've said, your gums recede, so you end up getting a lot of space between your teeth, and food gets stuck in there very easily. So I suggest to do flossing, use a proxy brush, and use your toothbrush as well. But your hygienist can train you on doing all this. In terms of toothpaste, any toothpaste works as long as it has fluoride in it. You can use the Biotene toothpaste. This is this Colgate Prevident. This is a prescription fluoride toothpaste. So if you need something like this, your dentist can prescribe it. And this has a high content of fluoride, so it's going to straighten your teeth and prevent decay from happening. AMI paste is it's not really a toothpaste, but it's a paste that you apply to your teeth after you brush them, and this helps to remineralize the teeth. So if you're having a tiny little spot that could eventually become cavities, this is going to reinforce the tooth and prevent that from happening. And this is also a prescription toothpaste that your dentist can prescribe for you. The fluoride application is something that is done in the office. And it's like a gel that we apply to your teeth. And again, this reinforces the teeth and prevents decay from happening. You can also use any type of fluoride rinse at home. The office one usually works better than the mouth rinse. So you can get an application of fluoride in with your dentist, and then reinforce it with home rinses with a fluoride rinse. Another treatment is, this is a recent material that we're using. It's called Cervo Diamine fluoride, and it's very common to be used in children. And the way this works is that it stops decay. So you can see in these pictures here, there's decay going on around the front teeth of this child. And once we apply it, it turns black, but then there's not going to be any more decay on that tooth. It kind of arrests the decay. The downside to this is that it becomes black like this. So this is usually used in children because, especially when they get decay on teeth that are baby teeth, that eventually they're going to come out. So it's okay to have, as long as the parents are okay with it too, but it's okay to have a little dark spot on the teeth that are going to be there for maybe a month or two. But this works really well in terms of stopping the decay from happening. And usually with scleroderma, we see more decay in the back of the mouth than we see in the front of the mouth. Usually the front of the mouth is rather clean. The treatments for serostomia that we can prescribe or we can recommend Any artificial saliva that you can buy over the counter, like the Biotin products. Cafazole is another. This is a prescribed saliva substitute. It's a calcium phosphate solution that mimics the saliva and helps to balance the pH of the saliva. So try to lower the pH so that it doesn't reduces the acidity in the mouth too. Any sugar-free candy, especially with xylitol. This ice cubes. This is gum that it has xylitol in it. So if you want to have a candy or you want to chew gum, this is a good option. Make sure that it has xylitol in it because this is sugar-free and it also helps with your teeth as well. Fluoride applications, like we mentioned just before. And the other one is any type of medical treatment for serostomia. Now, for medical treatment, this is something that is going to be prescribed by your doctors. And what they do is they prescribe this type of medications called Muscarinic Agonist. And but the thing that you need to know about this is that they slow down your heart and they create construction of smooth muscles like the intestines and the bronchioles in your lungs, urethra, and your eyes. But they also increase the secretion of any glandular tissue. So increase the secretion of saliva, increases the secretion of gastric acid, and any airway mucosal that is in your body. There are two. You have here two examples of these medications. Again, this is something that your doctor will have to prescribe. But there's some contraindications to this. One of them is if you have asthma or COPD. When you have asthma or when you have this type of conditions, when you take these medications, it creates bronchoconstriction and increases the secretion of fluids in your lungs. So that can exacerbate the COPD. If you have a restricted airflow and then you're increasing the secretion inside your lungs, that's going to lower the ability to breathe into your lungs, air into your lungs. If you have a peptic ulcer happens when the acid erodes the inside of the stomach. And because this medication increases the secretion of gastric acid, it could make a peptic ulcer even worse. If you have any type of coronary disease is a disease where the blood vessels, the arteries that surround the heart, gets clogged. So the flow of blood around your heart is reduced. And if this medication reduces your heart rate, then it's going to reduce also the amount of blood that is going into your heart. So it's not a good thing to have coronary disease if you to take these medications. And with hyperthyroidism, if you have hyperthyroidism, that happens when the thyroid gland produces too much thyroxine, which is a hormone, and that increases your metabolism. So you have a condition that increases your metabolism and your heart rate, and you're taking a medication that reduces your heart rate. So that creates an imbalance in your heart and can cause arrhythmias. But this is something that your doctor have to explain and prescribe for you if you have to take any type of medical treatment for serostomia. With GERD, what happens with GERD is that we get the acid from the stomach flows back from the esophagus into the mouth, and that can erode the teeth, as you see here. You can see that the enamel is gone in most of the areas in the back of the mouth. So we have to work with the medical team to treat this type of condition, and it usually has to be treated aggressively. Sometimes we have to, for instance, this patient, I had to put crowns on all of her back teeth. So we have to do, major work to prevent any more destruction from happening. And your doctor has to prescribe any type of proton pump inhibitor. That's what PPI stands for. So Prilosec is an example of this. So these medications helps reduce the acidity of your gastric acids. So even if you still have GERD, if you still have acid flowing back up to your esophagus, it has a reduced pH because of these medications. You have to consult with a nutritionist to have a diet with low acid, no caffeine, no food at least 2 hours before bedtime, like we talked about. It's good to raise the head of your bed by using a wedge pillow or an adjustable bed. I happen to have an episode of aspiration pneumonia because of the GERD, and I ended up using a wedge pillow, and now I sleep with an adjustable bed. I'll show you in a minute. And you also need to have, if your GERD is very aggressive, you need to have an endoscopy to rule out what's called Barrett's esophagus. Now, Barrett's esophagus is a condition that happens inside your esophagus when there's too much acid flowing back up. With this disease, what happens, unfortunately, it happened to me too, is that the picture you see here is this is a normal esophagus. So you have the food that is coming down into the stomach. There's a sphincter here that opens and closes and lets the food into the stomach. So with this disease, this sphincter gets relaxed. So it opens up. And now acid can flow back into the esophagus. The lining of the esophagus is not used to having an acid surroundings to it. The lining of the stomach is created so that it can stand any high acid content. So when this sphincter relaxes and the acid starts to flow back into your esophagus, it irritates the esophagus. And that's what's called Barrett's esophagus, because this lining is not used to having such a high acid content. And not only the acid also will flow up, also any food that you had also, and that could go into your lungs and give you aspiration pneumonia, which is what happened to me. And we'll talk about it a little further down too. So if you have GERD, because of this condition, I recommend that you get a wedge pillow or an adjustable bed. The thing about the wedge pillow, I started using a wedge pillow and it works really well. But what happens at the end, like when you wake up in the morning, you slide off of it. So you end up sleeping all the way down in your bed. Now, that doesn't happen with an adjustable bed, especially the ones that raises your legs, because when you raise your leg, then you're pretty much wedged into that position and you're not going to slide down. You can get one of these, which is, a big size bed that moves all together, or you can get separate, separate bed frames so that your significant other doesn't have to be sleeping like this. Actually, I have that type. It's two twins frames, so I can raise my bed and my wife doesn't have to be, she can sleep horizontally still. And if she wants to raise her bed, she can do it too. But whatever works for you. But it's very important to have this because I'm telling you from experience, by sleeping horizontally and having the GERD, I ended up in the hospital with aspiration pneumonia because of the reflux. Now, two conditions that happen also with this disease is Macrostomia and Discoloracy. We talked about Scleroderma already, but Macrostomia is a small mouth opening, and Discoloracy is the tightening of your fingers. The Scleroderma Foundation has an amazing amount of content about everything about the disease, and it's wonderful to have all that information there. Here you have a link of exercises for hand and mouth, which are very, very, very useful, very, very good. But if you go into the Scleroderma Foundation website and just do the search of hands and mouth exercises, you're gonna get a few hits about exercises that you can do. It's a very, very, very good source of information. Now with Microstomia, small mouth opening, you can do physical therapy, so mouth stretching exercises. Another thing that we can do, this is commissurotomy. This is something that is done by an oral surgeon or a plastic surgeon. And it's a procedure where they cut a little bit the corners of your mouth to help you open up a little bit more. Now the dentist, what can we do to treat patients with macrostomia? We have to be very patient when we're treating you. Because like I said, we cannot stretch your mouth too much. We have to rely on stretching your mouth to get all the way in the back of the mouth. And if your mouth is really tight, then we have a hard time reaching way, way back in the mouth. Sometimes we have to modify our equipment. This is a regular hand, we call a handpiece, so this is like a regular dental drill. And but with scleroderma patients, sometimes we have to use a pediatric equipment. So on this side, you see the head of the drill. This is a regular drill, and on this side, this is a pediatric drill. So as you can see, it's much smaller. So with a smaller handpiece, we can reach a little bit further back in the mouth too. The burrs, what I'm saying here about modifying burrs, the burrs are the drill bits that we use on a handpiece. They come to in a certain length, but we can actually modify them. We can make them shorter so that we can reach a little bit further back in the mouth. So you don't have to open so much for us to reach way back there. Another thing that we can use are mouth props, and this is also common to use because not only you may have a hard time opening your mouth, but also your jaw gets tired too. So these things, they come in different sizes, so you can see there. And this thing, we just put it in your teeth and you bite on it, and you can rest your jaw on it, and it's going to keep your mouth open. It will be able to work on the other side. This is an example of macrostomia. So this, as you can see, this patient has, tightening around the lips and the cheeks. And this may seem like it's a good amount of opening, but for this patient, I had to order pediatric equipment to treat her. Even the dental mirrors, the round mirrors that we use, the pediatric one is much smaller. So I had to order pediatric instruments to be able to treat this patient. And you will know if you have microstomia. Like normal mouth opening, you should be able to put 3 fingers in your mouth. If you cannot put 3 fingers in your mouth, then you're starting to have a little bit of problems in terms of this. And that's how actually my rheumatologist realized that I had scleroderma. So normal mouth opening is 3 fingers in your mouth. And this patient, she can barely open her mouth. So I had to use pediatric equipment to treat her. What are the common dental findings that you see in scleroderma? Not only scleroderma, but also, even normal patients. And one of them is tooth decay. Now, you see here on number 1 is a healthy tooth. And on one side is you see the whole tooth, on the other side we see like a cross section of the tooth. So on the top part, this is the enamel. So this is what you can see when you open your mouth and you see your teeth. This is what you can see. That's the enamel. The second layer is called the dentin. And then the third layer, which you see here in like dark red, this is the pulp. So this is where the nerve resides, the nerve and blood vessels. So this is a healthy tooth, no cavities. So on number 2, you can see a little bit of a dark spot here. So this is decay in the enamel. It hasn't progressed further. It's only in the enamel surface of the tooth. Now, when we treat this, if I were to treat you with this type of decay, you don't even need to be numb because you're not going to feel anything. You're not going to feel the drill. You're not going to feel anything when we're treating because it's still on the surface and the enamel surface area. Then when it progresses, it reaches the dentin. So you can see here now the dark spot is now in the dentin area. So this is where you start feeling sensitivity to cold, especially to cold. Sensitive to cold, it may be a little bit lingering when it's sensitive. You may or may not need to take any pain medications to try to calm it down. It's almost like it makes you aware that something is going on in your teeth. So usually that's the decay that is in the dentin, because in the dentin, there's communication to the pulp, to the nerve. So it's sensing signals to the nerve saying something is wrong here, and that's the nerve responding, and that's how you feel. That's why you feel pain or discomfort, I should say. And then if it still progresses, then it reaches the pulp. So when it reaches the pulp, you usually have a big hole on the tooth, and this time you have sensitivity to cold, but you also have sensitivity to hot. It's lingering. It wakes you up at night. You could even feel your pulse on the tooth. And you have to take pain medications for this. So this condition will require a root canal. So this is usually when you get a root canal, it's because the decay reached all the way down to the nerve. Sometimes it reaches the nerve and you don't feel anything. Sometimes it reaches the nerve and you feel very, very painful. Eventually, with time, you can have an abscess, which is this little bubble that you see at the end of the root. So this is an infection because the nerve is now dying, and it creates an infection at the apex of the root. Now, this can still be treated with a root canal, excuse me. And as long as there's not a lot of destruction on the tooth, we can still save the tooth. Another thing that happens is gum disease or periodontal disease. And so the plaque, that's that film that forms around your teeth, can work in two ways. It can affect your teeth by causing decay, by causing cavities, or it can affect your teeth by causing gum disease. So what happens with that film around your teeth is that it catches calcium ions from your saliva and it becomes hard, it calcifies. So that's what's called tartar or buildup. And that tartar is very rough and irritates your gums. So this is when when you have a buildup that starts to irritate your gums and you get a bleeding, especially when you brush, or sometimes it's spontaneous. That's called gingivitis. That's inflammation of your gums. When that progresses, then you start to lose bone that's holding your tooth, and you start to get pockets around your teeth. So the bone that was holding your tooth starts to recede because that buildup is eroding away your bone. And when that progresses, then you get periodontitis, where there's a lot of bone destruction and there's not much bone holding the tooth. Now, usually people that have gum disease don't have much cavities. And people that have cavities usually don't have gum disease. So when you're in a stage like number 4, when you have periodontitis and there's so much bone loss that there's no more bone holding the tooth and the tooth needs to come out, that usually comes as a surprise to some patients because they see, what do you mean you have to take my tooth out? I don't have any pain, I don't have any problems, but there's no more bone holding it. So this is more of a silent disease compared to cavities. And this is something that your dentist should be aware of. Well, they are aware of, but should monitor with your condition. Another dental findings that we could see is internal or external root resorption. External root resorption is very, very common in scleroderma. And what it is this is unknown. We don't know why this happened, but for some reason, the tooth starts to have, it's almost as if the tooth has started eating itself from the inside or from the outside. So internal is when the tooth, it's almost as if you're getting an internal cavity inside the tooth. And external, it happens usually around the root surface. So it's almost like getting a root cavity. And it's also very common when there's trauma. This X-ray that you see here is a patient that has external root resorption. So if you see carefully here, there's a shadow inside the tooth. And this is external root resorption. Now, this patient had a trauma about 20 years ago. I think he fell off a bicycle or something like that. He hit his front teeth and fractured the teeth. They ended up repairing them, and this tooth eventually ended up getting a root canal. So that's why you see, when you compare both of them, one of them, you can see all this dark area inside the tooth, but this one has a wider area here. So this is a root canal tooth. When they do a root canal, what we do is we go inside the tooth, we take the nerve out, we take the blood vessels out, we clean inside the tooth, and we fill the inside of the tooth with a plastic material that shows up like this on an X-ray. So external root resorption is very, very common when there's trauma, and it's also very common in scleroderma. It can affect one or several teeth. It's usually very difficult to diagnose because sometimes you may see on an X-ray that something that may look like external root resorption, but you're not quite sure. And then, 3 months later, 6 months later, you take another X-ray, and then the whole tooth is, affected with the external root resorption. So it's very difficult to diagnose. Usually the treatment is not successful. So sometimes if there's too much involvement, there's not much we can do. Now, in scleroderma patients, when you see too much external root resorption, as long as the tooth is still there and the patient can function, we would leave it alone. Sometimes with scleroderma, in terms of dental treatment, sometimes no treatment is an option, even if there's something going on in your mouth. And I'll tell you a little bit more about it, showing you another case. And you should consider replacing the teeth if that's the condition that's going on. But sometimes, like I said, and I explained a little bit further too, that treatment, sometimes doing nothing is going to be the option to follow. Now, how do we know with how this is happening? How can we diagnose these situations? We use X-rays. Now, there's 2 types of X-rays that we can do. This is one of them. This is a panoramic X-ray. So if you have microstomia, if you have a difficulty opening your mouth, this is a good option to have. So this X-ray, this machine goes around your head and takes a big picture of all your teeth. So you don't have to open your mouth for this X-ray. If you have a small mouth opening, this will be a good option for you. But the problem with this X-ray is that it gives me an overall view of your whole mouth. It gives me an idea of what's going on, but it's not a very precise X-ray. But it's a good option to have when you have a small mouth opening. And the other option is a periapical X-ray, which is a traditional X-ray that you're familiar with, that your dentist, dentists been doing for years and years and years. Nowadays, we do it digitally, so it's a little bit easier. The difference is now the sensor compared to the old type of X-rays. The sensor is a little bit thicker. So if you have a small mouth opening, we may have a hard time getting the sensor in your mouth. So the X-rays may not come out that great, but we do the best we can consider your condition. So with these X-rays, we can see, individual teeth a little closer and with much more detail. Now, this is a scleroderma patient. And you can see this patient is missing some of the back teeth here. And there's this shadow that you see. I'm going to show you this X-ray again in the next slide. This is external root resorption. There's also going on here. There's also going on here. So this patient has also very limited mouth opening. And I cannot put her too far back in the chair too. So that limits the way that I can approach her case too. But this patient can function well the way she is right now. I treated a couple of teeth for her. This tooth here that you see that is a little bit smaller, it has a temporary crown on it because it was so broken down that there's not much that I could do, but I didn't want to pull it because she was still functioning. So I decided to put a temporary crown on it, and I cemented that crown with a permanent cement. So it's sort of a, long-term temporary, if you will. And that way I could keep that tooth for a little longer as I can, as long as she can function well. So this patient, even though there's so much going on in her mouth, but she can still eat, she can still function. If I start taking teeth out, all the teeth that had external root resorption, she's going to be miserable because she won't be able to eat anymore. And then in order for me to provide something that she could eat, I will have to take impressions in her mouth or maybe consider implants. And impressions, when you cannot really open up your mouth too much, is very, very hard. So, I have to sometimes find a balance, like, should I treat, no treat? So I usually ask the patient, how they function normally in the mouth. If this patient tells me that, I have there's no way for me to chew. I don't even know what to do. I mean, I'm swallowing whole. I'm miserable. I'm not eating well. Then I'll consider a more aggressive treatment. But if the patient tells me that I can eat anything I want, I don't have any problems eating, then I will, close some of the areas that are very obvious decay, some of the areas that I can see that food is getting stuck in there. I'll try to close it. But for the most part, sometimes, that's what I was saying before, that sometimes no treatment, it could be an option, as long as you can function well. If you cannot function, then we have to do something about it. So don't feel bad if your dentist doesn't do much for you at some point, because it could be because doing something is going to make your life even worse. Now, if your life is not good in terms of your dental condition, then obviously, yes, we have to treat. So this same patient. So you can see the shadow here around the tooth. So this is external root resorption. You can see the shadow here as well. And you can see the shadow here. This tooth had a root canal. That's why you see the white inside of it. So a few teeth here and there have external root resorption, but she can function. Now, this is another case. And I'm going to show you X-ray one by one what happened here. So when this patient came initially, she had 2 crowns on these teeth. So these are crowns. These are root canals. And if you see, the crown has a structure, which you see here in white, and then the porcelain is on top. The porcelain mimics your tooth. So this looks like a normal tooth. So this is a crown or a cap. Now, if you see, for instance, let's take this tooth right here on the bottom. This is silver filling on the tooth. And if you see where the filling ends and the tooth starts, it's a good transition. Same thing here. You can see that there's a nice smooth transition from the filling to the tooth. But when you look at this one, if you see where the crown ends and the tooth starts, there's a gap there. There's a gap here too. There's a big gap on this one. Now, these 2 teeth have root canals. So when you have a gap between the crown and the tooth, or between a filling and the tooth, bacteria can get in there and cause more decay. And because these teeth are root canal, this patient is not going to feel anything. So that decay could still progress, and patient has no idea. And the next thing you know, that crown comes off and there's no more tooth left to work with. And the tooth needs to come out. So I told her, we need to replace these 2 crowns. That usually comes as a surprise to patients, because why do you need to change my crowns? I can eat it fine. I have any problems with it. But we can see that this is a big potential problem for them. So I replaced those 2 crowns. And this exercise, I'm trying the crown in, the new crown. But then I see this going on here. So something is happening on this tooth here. So I told her at the time, and same situation here. This tooth is root canal too. So there's a cavity going on here, and this patient is not going to feel anything. So I said, we need to address this. Now, normally when we see this type of situation so far back in the mouth, a tooth that has a root canal, the best option will be a crown. Now, because this patient cannot open her mouth too much, doing a crown on that tooth is very, very, very difficult, because we have to shave down the whole tooth. We have to take an impression of the tooth, and we need to get all the way back there and all the way around the tooth. So it's a very, very involved treatment for somebody who can barely open her mouth. So if I try to do my best to do a crown there, I'd probably do more harm than good. So what we did is we did a filling on the tooth. So I cleaned out all the decay and put a filling on it as best as I could to reach as far back as I could to cover that area. Then a few months later, she came back much after my transplant. And now this tooth is decayed. So now this tooth has to come out. because there's so much decay there. I actually went in there and cleaned it, but there was so much decay and there was so little tooth structure remaining that it wasn't really worth it. So we ended up extracting that too. So you can see how this can progress rather rapidly in these situations, and especially way back in the mouth. If you have a hard time reaching back there to clean, this could progress really rapidly. So all those aids that I was telling you about, all that interaction with your hygienist, make sure they teach you how to clean your mouth, how to treat it, clean it well, and maintain it at home. Regular follow-ups with your dentist are really, really important. So this is the same X-ray that you just saw, the initial with the openings around the crowns, the trying of the crowns with the cavity here, and then the filling done, but then eventually this tooth had to be taken out. This is another patient where you can see the same situation going on. There's a little bit of opening here. This is a little bit bigger here. So this cavities way in the back of the mouth with somebody who cannot open the mouth too much, and we can put the chair back so far, is very, very difficult for us to treat. And sometimes dentists are afraid that going in there we're going to destroy more than, we're going to do more harm than good by going in there. Dental implants, like I said, there's no contraindications for it, but each case is different. Implants are not for everybody. If you're not familiar with a dental implant, it's a fixture that is placed in the bone, and then the tooth is placed is inserted into the implant, and is usually held down by a screw and replaces the tooth that is missing. This particular case, this patient had missing these incisors. So 2 implants were placed. You can see the screw here holding this device here. This is called an abutment. So this is shaped so that it can receive the cap on top. So these are the caps on the implants. So this is something that we can do with dental implants, but again, it's not for everybody. Each case has to be evaluated very, very carefully. And the amount of opening of your mouth is a big limitation for us to get way back there and place them. When we place them, we have to put it on a handpiece, on a drill. And so the drill plus the implant is actually rather big. So if you have a hard time opening, then it's going to be difficult for us to get the implant where we want it to be. And the position of the implant is also very critical too. You want an implant to be exactly where the tooth is supposed to go. I don't want an implant in this direction where the tooth goes in this direction. So I want to have it center in where the tooth is supposed to go. And if you have a limitation on opening your mouth, it's going to be very, very, very difficult to do. But at the same time, there's no contraindications to getting implants for scleroderma. You can have an implant on the front tooth, like this case here, as long as you have your back teeth to chew on. Like I was talking at the beginning, the front teeth are there for chewing, for biting into things, and the back teeth are there for chewing. If you're missing your back teeth, you're using your front teeth for chewing, and they're not made for chewing. So if this particular case, this particular patient didn't have any back teeth, I could make the most beautiful crowns here, but those crowns are going to fail. And the teeth are going to start breaking down, because when you use them for chewing, they're not made for that. So you're overloading your front teeth. So very, very important to have your back teeth. Usually people say, no, I don't want a crown there or an implant. Nobody's going to see that. I want the one that people are going to see. Yeah, but the back teeth are there to protect your front teeth. If you don't have them, your front teeth are going to fail. So make sure your dentist knows about your condition. Make sure that you get annual checkups and x-rays and regular cleanings, usually every 6 months, but in your particular case, maybe have to be done every 4 or 3 months. Bring your list of medications and physicians to your dentist so that they can work together in coordinating your treatment. Make sure that you get a good relation with the hygienist as well, and make sure that they teach you what would be the best possible way to clean your mouth at home. You may have to bring your toothbrush, or you may have to brush in front of them and ask them to show you would be the best way to clean your teeth at home. Schedule the best time of the day for you and your dentist, especially for your dentist, because again, it depends on your condition. I have patients that you never think that they have scleroderma, and I have patients that can barely open her mouth and open her fingers. So depending on your condition, but if you're a patient that has a small mouth opening that we cannot put too far back in the chair, sorry, then you have to coordinate the appointment with your dentist the best time possible. For instance, for us as dentists, we don't want to have a very, very difficult case early in the morning, because then we're burned out for the rest of the day. I don't know if you get what I'm saying. So the best time for both of you to work well. If I know that I'm going to have a difficult patient to treat, I'd rather have him or her, later in the day, or if it's going to be a long case, I'd rather have the patient only that day. So if I'm burned out at the end of the session, then I don't have to worry about, treating all the patients, or I may have to arrange patients so that if I see you in the morning, if I see a very difficult case, scleroderma case in the morning, then I will have a couple of small fillings in the afternoon or something like that. So coordinate it so that, you don't want to be, and at the same time, I don't want to have a very difficult case, not really a scleroderma case, but let's say, a full mouth reconstruction in the morning, which you usually burn out by the end of the session. Then next patient is going to be a scleroderma patient, then I won't be able to perform well. So that's why I'm saying that's the best time for you and your dentist. It's good to do physical therapy before the appointment, if possible, to do like mouth stretching exercises. Usually dental offices are really cold, so make sure you bring a blanket or gloves or anything to keep you warm. Usually we have stuff in the office to keep you warm as well, but for the most part, usually dental offices are rather cold, so be mindful of that. Like I said, orthodontic and implant treatments are not a contraindication, and your dentist can coordinate with your physicians if you have any type of medication to treat serostomia or to treat the reflux. Both have to be patients. Both you and me have to be patient. We are going to do the best possible treatment for you, considering the limitations. And sometimes, like I said, no treatment is going to be an option. So don't get frustrated with your dentist if your dentist have a hard time treating you, because it's not easy. I had actually a few years ago, I had to have a root canal done, and my endodontist had a hard time getting way in the back of my mouth because of the limited, and I don't have that much limited opening. I mean, I cannot fit 3 fingers in my mouth, but I'm not like the patient I show you yet. But he had a hard time doing the root canal on my tooth because of the small mouth opening. And get help on training with oral home care. Like I was saying, with the oral hygienists, make sure that they teach you how the best way to clean your mouth at home. Many dentists are trained to work with patients with autoimmune diseases. For the most part, dentists usually treat, patients that don't have much more of a big disease going on. So scleroderma is usually a rather rare disease to treat in terms of dentistry. But when dentists are being trained, we go through special care clinics. So we are exposed to treating special care patients too. And some general practice residency programs or advanced education programs like prosthodontics, like the one I did, we deal with compromised patients, especially in prosthetics. We deal with, we're trained to do maxillofacial prosthodontics. So we're trained to treat patients that lose, half a mandible, or patient who will lose the whole maxilla, or have a communication between the mouth and the nose, or a patient that will lose an ear. We can make prosthetic ears. We can make prosthetic eyes too. So that's part of prosthodontics training. So we're trained to treat compromised patients. So if there's a prosthodontist in your area, they should be able to treat you. But like Tina said in the beginning, and I'm going to talk to you about a little bit too, if you had anybody in your area, just let me know, or let Tina know, and she's going to let me know. Because we have a lot of, students from all over the country, and all over the world too. And we may have somebody in your area that we trained and we can talk to, and we can even also coach your dentist. If your dentist have a question, I mean, it doesn't necessarily have to be somebody that I trained. I mean, if they have a question about how to treat you, I'll be very happy to talk to them and explain what would be the best way to go for. Dental school is another option in order to get dental care. Again, because we are trained to also treat special care patients. Any hospitals that has a dental clinic is also a good option too. And this is Special Care Dentistry Association. It's an international organization that organizes healthcare professionals that treat patients with special needs. That's another option too. Now, if you have trouble finding dental care, feel free to email me or Dr. Leader. Dr. Leader information is there. And again, I thank Dr. Leader so much for sharing his material with me to be able to give this presentation. Like I said, we may have somebody that we trained in your area, or we can coach your dentist, or try to, it's not that we're going to tell them what to do, but at least we can, sort of explain the situation and what would be the best way to approach, or we can share the case. We can discuss the case together too. We can send x-rays back and forth and, say, what do you think we should do here? Okay, I think you should do this or that or the other. That's my office information. I'm going to put it up again a little further down too. If you're in the Boston area, I'd be very happy to treat you. If you want to come to Boston, more than welcome to. Again, the Scleroderma Foundation has a very, very, very good source of information. They have this brochure on dental care, which is fantastic. And just do a search, and anything related to the disease, you'll find it there. It's amazing. That's my office information again. Just in case, if you want to get in touch, I'll be happy to help you out. I'll be happy to coach your dentist, anything. Or, talk to a patient that is recently diagnosed, like Tina was saying, be happy to. That ends the part of the dentistry. Now, Tina, do you want to do the questions now, or you want me to go through my story and then do the questions at the end? What do you think?
Sorry, there I go, talking without unmuting. You think I'd get used to this by now. I want to just say really quickly to everybody, because there's been a few questions, and that is, first, thank you. What an excellent, excellent, excellent talk that everybody needed. You've given such great information, and we are recording this today, and everybody is going to be sent this link after we do our edits, so you can have it. You can take your time taking notes. You can pause it while you're doing it. And you know what else you might want to do? And I think this is a great idea. Share it with your dentist. If they don't have a big chip on their shoulder, maybe they might not mind watching it. Share the link with them. Let them watch it. Let them learn from somebody that truly understands the needs of somebody living with scleroderma. They might not think there's so much to this, but they might find out that there really is. And maybe as a result of it, you can start working with that dentist, and maybe they'll keep in mind some of the things that Dr. Del Castillo talked about, even when it comes to patients, being patient with the patient. So I just wanted to say that before anything, that we're recording it. You guys are all going to get a copy of the link after we edit it. And so that will help. I don't want to take away from your time, Dr. Del Castillo, to tell your story. So why don't you go ahead and do that? And when you're done, we'll go ahead with the questions. Okay.
Sounds good. Sounds good.
Thank you.
Okay. So I'm going to tell you now my story. So this is how I went from this picture to this picture. And when I had this picture taken, I already had signs and symptoms of scleroderma, but I wasn't diagnosed yet. But you can see clearly how my face changed. And actually, I grew a beard because I didn't like the way I was looked in pictures. So the whole thing started around 2009. At that time, we didn't have the girls. We just enjoying our time here in New England. I was playing in 2 different bands. I'm, amateur musician, playing in 2 different bands, visiting family. And at that time, I had a friend that was coming to visit, and we were planning his visit over the phone. And he actually mentioned to me, he says, you know, we've been talking for a while and you've been coughing a lot. And I didn't even realize it until he mentioned it. He said, what do you mean I'm coughing? Yes, you're coughing. You've been coughing the whole time we've been talking, you've been coughing. So I said, well, you know, let me research it. I'm going to talk to my doctors and see. So I started, I checked with my primary care, who's also from Venezuela, actually, and her husband, also from Venezuela, happened to be a pulmonologist. So I started to see him. And they did all sorts of tests on me. They had, you know, PFTs, these exercise tests where they draw arterial blood from your wrist. They have you do an exercise. Happened to be in a stationary bike, which I enjoy bike riding too. So this was good for me. I enjoy this. I didn't enjoy the, you know, the blood drawn, but this wasn't a big deal for me. I did this test. I don't even know how many times. And they didn't know what was wrong with me. They thought it was asthma. It wasn't asthma. They thought it was pneumonia. It wasn't pneumonia. They didn't know exactly what was wrong. The only thing I had was a persistent cough. So 2009, I had a lung biopsy. And they took a sample of my lungs, and that sample was sent to 2 different pathologists from 2 different hospitals. The hospital where I had the biopsy, and another hospital. And both of them didn't even know that someone else was looking at the sample. So that's a way to know. It's like a double blind type of thing, so that this person doesn't know that this person is doing the same study, so to see if they have a consensus. So when I got the results back, they gave me 2 diagnoses. They said pulmonary fibrosis or something that is called obstructive organizing pneumonia. Both conditions are treated with steroids. So I took steroids for close to a year, and the cough didn't disappear, but it got a lot better. In the meantime, I mean, I was functioning fine. The only thing I had was that persistent cough. I had no problem breathing. I had no problem exercising. I have no limitations. The only thing was the cough. So I took the steroids for about a year. That year, my wife became pregnant, and which was a blessing too, because we have a hard time. She had a hard time getting pregnant. We did IVF, I don't even know how many times, and eventually happened naturally. So thank God for that. So 2010, Emiliana was born, and I'm still okay. I'm still functioning properly. You know, occasional cough here and there, but no limitations. 2011, still playing in the band and practicing. You can see how my cheeks were showing the steroids that I was taking. Traveled to your area too in that year, and everything was fine. And at this point, they started to talk a little bit about transplant. And in December of 2011, I had a consultation with a transplant team at the Brigham and Women's Hospital, which is one of the hospitals here in Boston area. In December 2011, my wife was pregnant with a second daughter. So they told me, you know what? I mean, yes, your lungs are not great. I mean, we can see scar tissue in your lungs based on the X-rays and knowing from the lung biopsy. But they said, you're not sick enough to be considered for a transplant. So, okay, so it said, you know, we'll just kind of continue to monitor you. So fine. 2012, Victoria was born, and we're still, you know, carrying on normal life, you know, as much as we could. So everything was still the same, trying to adapt to, you know, having a family. And you can see here that my lips are starting to get thinner on these pictures. And at one point also, my wife told me, you know, she was going to take a picture of me, and she says, like, why are you smiling like that? And I was smiling like I used to smile, not knowing that my face was starting to look different. So 2014, still same thing, everything going on, sort of normal. I had a right heart cath. I think I had 3 of them altogether. One of the right heart cath had to be done also with exercise, which was a little bit, it wasn't easy, but they tell me, let's do this, let's do it. And I did it. So I'm still being monitored and everything. And this year, I started to notice the finger ulcers. And I also noticed that I couldn't close my fist the way I used to. So I talked to my pulmonologist and I said, I'm noticing these things. I'm getting these fingers ulcers. Every time I bump into something, it hurts really bad. And I'm getting the ulcers and I cannot close my fist as I used to. So he said, well, let me have you see a friend of mine who's a pulmonologist and rheumatologist. He had both specialties. And the moment he saw me, he said, you have scleroderma. So this was from 2009 to 2014. So 5 years later, 5 years from the initial signs is when I get diagnosed. So finally, we know what's going on here. I had also the motility test for the esophagus. For those of you who have never had it, it's not easy too. What they do is they go through your nose and they put a probe all the way down to your esophagus, to the stomach, and it measures how your esophagus function. So the esophagus is a muscle that when you swallow, it pushes your food down to your stomach. So that's what's called the motility of the esophagus. So this test measures how much your esophagus functions. So I have good motility in this upper portion of the esophagus, but very little back here, down here. And also the sphincter that closes the esophagus to the stomach that I was showing you before is also relaxed. So I get the GERD too. So finally I get a diagnosis, and they're still considering the transplant at Brigham. And then 2015 was a year that I ended up in the hospital 3 times. The first time was in end of January. I went to, actually, this is your neck of the woods. This is in Anaheim. I went to, this is a music convention that happens there. It's called a NAMM show. And I went to the show, and when I came back, I ended up with pneumonia. I don't know if it's something that I caught on the plane or maybe it's because of my condition, but I ended up in the hospital a few days because of the pneumonia. Then a few months, not that much later, I ended up back again in the hospital with that episode of aspiration pneumonia that I was telling you about. And I ended up in the hospital probably 5 or 6 days, but I wasn't supposed to be that long there, but actually I had to be taken in an ambulance too. So that's how bad it was. And when in the hospital, the doctor says, now is the time to consider transplant, because now we can see that you're starting to get worse. They knew about my diagnosis. So they knew it was scleroderma. They knew that my esophagus was affected. So they said, now that you're here, why don't you do all the testing that needs to be done before the transplant to get that done with? So I said, fine, let's do it. So that's why I stayed a little longer in the hospital, and they did all the tests. And in the meantime, I went back to normal, and we had these pictures taken with our girls, with a professional photographer, and I hate these pictures. I don't like the way I look in these pictures. Even though they're very good, it was a very nice photographer who took it, but I really don't like them. I'm starting to lose weight here too, and my face totally changed. The third time I ended up in the hospital. So the first time was the pneumonia after the trip to LA. Second time was the aspiration pneumonia. And the third time was from, because of the finger ulcers. It became so bad that I had to, they had to take me in, and they put an infusion of a medication that helps with the blood flow, especially peripherally, especially at the, at your hands and feet. So it's a medication that it's an infusion that has to happen within a certain, like 3 or 4 days or something like that. And you have to stay in the hospital for that. So when I ended up with the in the hospital with the aspiration, I met this scleroderma warrior, Maria Margarita Gamboa. And I actually met her before. We met over the phone from a common friend, 2 common friends actually, that they knew that I was having trouble with my lungs and I was diagnosed with scleroderma. They knew her, they knew that she had scleroderma, so they put us in contact. And she told me, she actually had the transplant, lung transplant done at Cleveland. And she told me, start doing pulmonary rehab. So I started doing pulmonary rehab because she told me. So if you condition, if you have lung involvement and you're being considered for transplant, or even if transplant is sort of like in the air for you, do pulmonary rehab. Please do pulmonary rehab because this is going to help you a lot. You need to be as strong as possible when you get your transplant, as strong as you can be. So do pulmonary rehab if you're even considering, or even, you know, the doctors are considering you for a transplant, do pulmonary rehab. And so she told me to do pulmonary rehab and I started doing it. And you can see that I have a beard here because I grew the beard after the last hospitalization, or the second hospitalization, I should say. I said, I don't like how it looked. I ended up in the hospital so long that I didn't shave. So I said, okay, this beard is a good way for me to hide my face because I don't like how my face looks like. And since then, I have a beard. So this is her when she came to visit us. She stayed with us for a weekend. 2016, still, you know, trying to struggle with it. Sometimes I get a 98 oxygen concentration. Sometimes I get a 90. Sometimes I would get an 85. Sometimes 82, 83. I don't think I ever reached, I may have reached the high 70s at some point. But the other thing too is that with this finger monitor things, we get also Raynaud's, as you're familiar with. So the blood circulation in your fingers is not the best. So this thing sometimes don't read at all. So I would occasionally get an 98, but I will occasionally get an 83 or 82. So I'm trying to keep up, you know, with life, going to the visit with the doctor. Me and my wife going out with a friend in his sailboat. So trying to enjoy life as best as I could. At this point, I was after the second hospitalization, I ended up with 2 liters of oxygen only for walking long distances, only for walking long distance. If I walk a long distance, I have to put the cannula in. And you know, for those of you who have lung involvement, you know, you try to avoid, or you don't like people seeing you with the cannulas in your nose. So I don't have that many pictures with me with the cannula, unfortunately. Looking back, I should have more so I can, you know, show it to everybody. But so I was on oxygen here already, occasional oxygen, like I said. I try to be brave and not use it as much, which is probably a bad idea. I mean, if your doctor is telling you do the oxygen, do the oxygen. Because what happened is that if you don't have enough oxygen in your system, the rest of your organs are going to start to suffer. So this is my PFT in that year. And you can see here, it's difficult to highlight, but it's 1.82 on February of 2016. So that's actually quite low for a PFT. So, you know, obviously the disease is progressing. It's becoming even worse at this point. 2017, sorry, I'm trying to still maintain a normal life. Again, occasional readings of the 90s. At this point, I wasn't playing in the band anymore, but the band had, in the summer, they have a anniversary gig. So they invite all the previous members to play. So I used to go and play with them every summer. And here we are in a concert, and you can see here the hoses for the car. I actually had the oxygen tank between my legs here. But, you know, if they want to take a picture, take the cannula away, type of thing. So So you're not gonna see much pictures with me with a cannula because, constantly I try to avoid it. But again, trying to maintain all my life. At this point, if I walk a long distance without it, I could tell, you could tell my heavy breathing. Even when talking, you could tell that, I have a hard time, maintaining a conversation because of how much air I can get in. So at this point, I'm still doing pulmonary rehab. And after I should go back actually 1 year, but anyway, I did all the tests for the lung transplant at Brigham, and it took them about, I want to say maybe 4 or 5 months to get back to me. And they actually rejected me for the transplant because of the scleroderma. So they said, we're not going to do it here. We can refer you to Cleveland or Pittsburgh. So I said, well, my friend had her transplant done at Cleveland, send me to Cleveland. And she had scleroderma too. So, same case, they may take me. At the same time, I contacted Massachusetts General Hospital, which is where I'm doing the pulmonary rehab at. And I said, I'm being rejected by Brigham. Can you take a look at my chart and see if you're going to take me? And they also said no. So now I have Brigham rejected me, Massachusetts General Hospital rejected me. I'm waiting to hear from Cleveland. Cleveland also rejected me because of the scleroderma. So my only option was Pittsburgh. And I didn't know what to do at that point because I don't know anybody in Pittsburgh. I will have to sell my practice, move to Pittsburgh, and, I was in that quandary. And in the meantime, I'm still doing all the pulmonary rehab, and I'm talking to the therapist who's helping me with the pulmonary rehab, and I'm telling her all this story. And I said, this hospital rejected me, the other one rejected me, they rejected me here too, so I don't know what I'm going to do, blah, blah, blah. So anyway, you can see me actually here with the cannula because I had to do the pulmonary rehab with oxygen. I couldn't do it without it. And so it turned out that physical therapist was part of the lung transplant team at Mass General Hospital. So every time the team met and discussed cases, and we should get a patient like this, we should get a patient like that. So every time they met and discussed, she always raised her hand and said, hey, but what about Luis? I have the patient. What about Luis? So finally, Mass General said, yes, we're going to take you. The reason these hospitals will reject you is because we're a high-risk patient for them. Usually hospitals get grant money to treat these conditions, to treat, not condition, but to do the transplants. And they have to show good numbers. So when they have a case that is not going to show a good number, they may say no. So that's usually the reason hospitals will reject. But Mass General took a chance and said, we're going to do it. Actually, Pittsburgh was going to do it too. But Mass General said, yes, okay, perfect. I'm staying at home. And so then this is when I had the, how bad the ulcers were getting. And I had the infusion to help. This actually healed really well. But this is how bad they were. So 2018, I'm still trying to maintain a normal life. This is a graduation ceremony from Tufts, and you can see I'm holding the cannula here. Of course, I had to walk with the authorities, to the podium, and I had to walk with my oxygen tank. Because at this point, I'm pretty much 24/7 with oxygen at this point. Another friend came to visit in my office, and you can see I'm holding the cannula here because I didn't want to have the picture taken with the cannula. I had a concentrator at home, so I was sleeping with 5 liters of oxygen. Even with 5 liters of oxygen, I would get out of bed, go to the bathroom, and come back, which was, just a few steps away. Get back to bed, and I will be panting with 5 liters of oxygen. So still declining. I'm still doing pulmonary rehab. I'm losing a lot of weight too. And at this point, you can see here that I'm using a mask for the exercises. No longer a cannula, because now I think it was 7 liters now to be able to function, especially for exercises. Because after 5 liters, the cannula is not big enough to carry that much oxygen into you. So you have to use a mask. So that's why I'm wearing a mask on this video. But I was determined to keep going. And I said, you know, I'm not going to stop working. I'm going to work until I get the call. I was listed in March of 2018. So I kept working, and you can see me here with the tank. So this time I'm using it all the time. And before, I will keep it in my office and put it on. And then when my patient is ready, I will take it off, go see the patient, come back, put it on again. And just walking from the operatory to my office, I will be panting. But I was trying to, you know, I didn't want to show that I was having lung issues when it was very, very obvious that I had them. So if your doctor, again, prescribes you oxygen, use it. Please use it. So July 22nd, 2018, I had the fortune of having my family visiting, part of my family, actually. I had my brother with his wife and their children visiting from, they're living now in Guatemala. My cousin and her husband and one of their kids, they're living in Canada. And my mom was actually also visiting too. So that day we had a big breakfast with everybody in the family. And me and my wife had tickets that afternoon, to go see the band, the Foo Fighters, at Fenway Park. So we go to Fenway Park. We got there around 4 o'clock. At this point, I'm using, because I knew I had to walk around the park. I'm carrying a portable concentrator, and I'm carrying an oxygen tank, because the oxygen tanks that I had were not that big. So I didn't have enough oxygen to last for the whole concert. So I brought both of them. So we got there around 4 o'clock in the afternoon, and we're standing in line to get in. And my wife, we were probably like the 10 group of people in line in front of the entrance. And my wife goes to the front and asks for if they had any type of handicap services. And the guy says, oh yeah, we have handicap services. You don't have to stay in line, just come right in. So, but the moment she steps out of the line to go ask the guy is when I get the call. So when she comes back and says, oh no, we don't have to stay in line, we can go right in. Says, no, we're going to the hospital. So she's like, what? And she started screaming and yelling. And then the guy behind her, are you okay? And she's like, she got a call from the transplant. And at this point, I had 2 cannulas in my nose. So I drove myself to the hospital. And this is when I got to the hospital. And I'm texting friends and posting online. I got the call. Let's see if this happens. And I got at the hospital at 4:30 in the afternoon. And when you get the call for a transplant, whether it's lungs, kidney, liver, anything, you get the call, you go to the hospital, they prep you. And just before you go into the OR is where the surgeon looks at the organs that he or she is going to put in. And they make the decision right then and there if the transplant is going to happen or not. So even if you get the call, that doesn't mean that you're going to get a transplant. So I got the call, I got there and 4:30 in the afternoon, they prepped everything, and I waited in a room until about probably 2:30 in the morning, maybe close to 3 in the morning. That's when they brought me down. And at this point, it's still unknown if this is going to happen or not. So they take me down, and I'm outside of the OR in one of those stretcher beds with, blood lines in me and everything, and the nurses are running around. And I hear one of the nurses said, Dr. V said it's a go. Dr. V is a surgeon. So I go to her, I said, did I hear right? Did you say Dr. V said it's a go? And she says, yes, you're going in. So they took me in, and I must have gone in inside the OR probably around 3:30 in the morning of the 23rd. And they say the actual surgery started at 5 in the morning. And by noontime on the 23rd, I was in ICU. So I slept, I woke up on the 24th, right around 3 in the morning again, is when I woke up. I was intubated, and they take the intubation out, and this is me the next day. And if you see, I'll play the video again if I can, but my breathing is still shallow, even though I had already the transplant. And I noticed that, I think it was that day, but you can see my wife is saying here, say hi to the family. I'm saying there's a little bit of pain, but I'm okay. And I realized that of the shallow breathing, and I said, well, okay, I have new lungs. Let's see how much I can breathe. So I started breathing in, and my normal breathing that I was used to before the transplant, and I noticed that I could pull even more air in, and I could pull even more and even more, and that's like, oh my God, I can breathe now. And that was an eye-opening experience there. So here's me in the ICU. These are the two physical therapists that work with me, and this is Abby. This is the one that advocated for me to be accepted. So she's the reason I'm alive right now. They came to visit. So this is the next day. They give you this long-shaped pillow. In case you need to cough, you grab the pillow so that it helps you when you're coughing. And this is me walking the second day.
Second day walk. All good.
All good. And that's an X-ray of the new lungs. And you can see here these little things that look like a slinky, like a spring, and those are the staples that held the stitches together. I mean, there's not stitches, but the staples that hold the skin together. And they do what it's called a clench shell incision, where they cut from armpit to armpit. You're gonna see, I'll show you the picture of it. So they open like a clamshell. That's why it's called a clamshell incision, to get into the lungs. So that's my daughters when they came to visit. And you get to that pillow, you had all the nurses and everybody sign it. So that's Emiliana signed. Daddy got his new lungs. Love, Emiliana. That's her. And that's again the picture of the lungs. You get a lot of X-rays of your lungs after the transplant. And so this is me. I stayed in ICU maybe 2 extra days, and that not because there was anything wrong, but there were no beds available on the lower floors for me. Now, when you're transplanted, you cannot share the room. You have to have a room on your own. So there were no rooms available, so I had to stay in ICU a couple of days extra, which it wasn't a big deal. I mean, it's not very comfortable, but 2 extra days is not a big deal. So this is me with no cannulas at 99% concentration here. And I got this stuffed elephant from former students. If you don't know, the Tufts mascot is an elephant. So my former students sent me an elephant, a big elephant, because of Tufts, as a get well gift. And they put masks on them. This is pre-COVID, obviously, but because I was immunosuppressed, I am immunosuppressed, but at the time, anybody who walked into the room had to wear a mask. And every time I went out after the transplant, I had to wear a mask. So this is even, I'm wearing a mask even before COVID. So this is me leaving the hospital. And I'm using a, I forgot to mention that I'm using a, having a feeding tube now. So I have a feeding tube put in when I was listed. I didn't use it until after the transplant. So after the transplant, I spent 11 months with nothing by mouth, everything tube fed. So you can see the hose there of the tube feed. And this is when I got home. And you can see that that backpack that holds the food and the hose that and I lost a lot of weight there. Very excited to come home. So at this point, well, you know, trying to get used to a new life and trying to get used to a feeding tube, which wasn't easy at all. And it was actually very frustrating, and for several reasons. One of them, not being able to eat is a big thing. And the other thing that really bothered me was that occasionally when you connect the hose of the feeding tube to the one that you have in your body, sometimes it will disconnect and I wouldn't even notice it. And next thing I know, I'm soaked in formula, the formula that is coming out of the pump and the formula that was already in me. So it was very, very frustrating. But you know, I'm trying to adapt. I'm still doing physical therapy. This time I don't need to use oxygen, but I have to wear a mask everywhere I go because of the immunosuppression. And trying to get used to life. A friend of mine gave me this T-shirt that has this lungs with a neck of a guitar there, and you can see the hose for the feeding tube. And trying to regain weight because I lost a lot of weight and I lost a lot of energy too. I had more energy when I was in the hospital than when I got home. When I got home, my energy went really, really down. And you have to go back to the hospital very, very frequently after the transplant because they have to monitor. They have to do chest X-rays. They have to do blood work to check the levels of the anti-rejection medications. So at the beginning, you go 3-4 times a week to get blood work done. And at the beginning, I couldn't even walk in the hospital. I had to get a wheelchair to wheel me into the hospital to get all the tests done. I didn't have any energy to stand or to walk. And I would say maybe like a month later or 3 weeks later, after going to the hospital, I still use the wheelchair, but this time I'm using it as a walker. So I'm holding the wheelchair, I'm trying to walk, but I'm keeping the wheelchair in case I get tired, I use the wheelchair. And eventually I ended up, you know, I'm not needing it anymore. But at the beginning, it was hard. I'm going to show you now the scars. So for you who are maybe sensitive, it's just a warning. So this is how the scar looks like. So you can see they open from armpit to armpit. These are the staples that they come out. I think it was 2 weeks later. You don't feel a thing when they come out. I actually didn't have any pain. I wouldn't say any pain. I mean, I had a little discomfort, but I didn't really have pain. People think that, you know, this is going to be extremely painful. I actually rejected to have any type of opioids, painkillers. And so they prescribed what's the name of it? I can't remember right now, but they prescribe a non-opioid painkiller because those opioid painkillers can cause addiction and they're very, very, very dangerous. So I didn't want to take them, and I asked not to give them to me. So they gave me another one. Tramadol is the one that they gave me. And if I took 5 pills, that was it. Pain, I didn't have. Discomfort, yeah, maybe a little bit, but I didn't have any pain. Like terrible pain, no. So I'm trying to do, normal house chores and adapt to carrying a backpack with a feeding tube and trying to get a normal life. My wife had to drive me every time we go to the hospital. You cannot drive for 3 months, I think it is, in case you get into an accident or your steering wheel, crashes into your chest. I mean, it's very, very sensitive, that area at the beginning. I went back to work 6 months post-transplant, still carrying my feeding tube, and taking the family out for lunch or dinner was hard with them ordering food and you don't order anything, so that was a bit of a struggle. But eventually, like I said, 11 months after the transplant, I started eating and everything started to slowly get back to normal. My oldest had her first communion. And at this point, I'm starting to eat, I'm starting to gain weight. PFTs are starting to get better and better and better. I managed to be able to go back to riding my bike and riding with my daughter. And that summer we traveled to Florida. And so we ended up, moving into a new house. So things are starting to get better and better, thank God. And this is Abby again, and Jessica, the physical therapist. So this is September. So this is a year and 3 months after transplant. And Boston has a bicycle ride that they do every year. It's called the Hop on Wheels. And I've done it a few times before. I've done it 4 times before. And that year I said, I'm going to do the Hop on Wheels again. So Abby, the physical therapist who saved my life, she already moved to Brooklyn, New York. And she came from New York to do the ride with me. This was September of 2019. So we did the ride together. So this is a big ride. They closed most of the main streets in Boston only for cyclists. So you can see the number of cyclists there. And this is me going up a hill a year and 3 months post-transplant. I was slow, but I did it. And I finished the ride. You can actually see in this picture the feeding tube right there. The feeding tube didn't come out until, I think it was 7 or 8 months after I started eating. So that was annoying to have that thing hanging there too. So that was my birthday that year, December 2019. We traveled to Canada and just trying to get back to a normal life, skiing with my daughters, enjoying skiing and snowboarding, and riding both my road bike and my mountain bike again. And so this is the first communion for my youngest. They both wore the same dress, which is the dress that my grandmother made. This dress is almost 50 years old. And everybody in my family, all the girls in my family wore it. So my girls did too. And this is December of last year. So this is a recent picture. Everything, thank God, back to normal. And 3 people that I have to thank. One of them is my wife for, struggling with all this together and holding the family together. Abby Folger, who saved my life. And Maria Margarita Gamboa, she's the Scleroderma warrior that I was telling you about. Sadly, we lost her last year from the disease. This December would have been 6 years since her lung transplant. And but she started that year, 2020, she started having a lot of trouble, especially with her kidneys. And that's actually common with this because of the medications that we have to take. They take a toll on your kidneys too. So it did in her case. She also had other medical issues going on, but we sadly lost her to the disease. But she also is one of the reasons that I'm alive today. So her, Abby, and my wife saved my life, and that's it. Hope you like it. Hope it brings you hope.
Thank you, Dr. Del Castillo. I'm trying to do two things at once, like hitting my head in this. Thank you. Beautiful story. And I think what's really important is that people realize that there is life after scleroderma, even in some of the most serious moments, that you're still able to go through the things that you did and make it where you are today. Even the things that you did after transplant, the things that you did before, the things that you did even though you had complications, it didn't stop you. And we have a couple people that I know on today's platform that are waiting for lung transplant.
Good.
So hearing your story is something that I'm sure that they really appreciate. And again, your perseverance, your strength, your optimism, and your family support, I think makes a huge difference too. So I want to thank you very, very much for sharing that with us, because that's a very personal story and it was something that you shared with us. So thank you so much.
No, my pleasure. And you know, if you're waiting for transplant, or even not necessarily waiting for transplant, or dealing with this disease, it's okay to get frustrated. It's okay to get depressed. Just make sure you get help too. There were occasions where I don't know if I got depressed because I'm very laid back, but there was one particular instance when I was doing pulmonary rehab, and this is before the transplant, and I'm doing the exercise and I'm thinking, you know, why this had to happen to me? What, you know, I don't do anything wrong with anybody. I mean, I'm not messed with people. I mean, why? But, you know, I'm doing all this, thinking all that stuff in my head, but I'm not showing that I'm thinking that. I'm, you know, if you see me, I'm just a normal person, you know, normal Luis. And I'm doing the exercise and somebody is behind me doing exercise as well. And this person behind me is very, very excited about the exercise. So I can hear him. He says, okay, what do you want me to do now? So, okay, so now let's do steps. Okay, let's do the steps. And the guy goes and does the steps. I'm not looking at him, I'm hearing him. What do you want me to do next? Okay, let's do this. Okay, let's do it. And now what next? Okay, let's go. Let's get this on. And so I'm thinking all that stuff in my head, like, why me, you know? And this guy in the back of me is all excited about the exercise. And when I turn around, this person had no arms. And he's excited about his exercise. And then I said,
wow,
what are you complaining about? You know?
wow, you're gonna make me cry.
So that was eye-opening too. So, you know, it's okay to get frustrated, but don't let it take you down.
That's what I always say. Everybody can have a bad moment, but don't let the bad moments get to the point where they overrule the good moments, and trying to be optimistic. So yeah, you sharing that story is very heartfelt. And as you're talking, people are sending in notes about how much they appreciated it. One just did right now. Love it that you would admit you don't like your facial changes. Very few people understand that.
Oh yeah.
I wanted to say we went over time, and I want to still go over the questions, so we will have it in our video. So if anybody has to go, you're more than welcome to end the meeting. But I want to say two things. We're going to go over all the questions so I can have them on video. But before you go, we would really like to take a picture with everybody. And if you don't want to be on camera, you can just turn your camera off. But we wanted to do a snapshot of everybody. We have about three screens. And so if that's okay, we'll probably count to 3, and we're going to just do a snapshot of each. I think there's 3 screens. So again, if anybody doesn't want to be on the camera, you can turn your video off. And if you do, then I think on this count of 3, I think we're going to just all put up our hands and wave. Does that sound right, Emmanuel, Andrew?
Yep, I got it.
Okay, you got it. So you want to tell us when?
All right, ready?
Okay, you got ready, everybody?
Wait, everybody's still jumping on.
Okay, 1, 2, 3.
Got it.
All right. Is that all the screens, Emmanuel, or do you have to go one by one?
Nah, I think I have as many people as turned on their cameras, so about 50 people.
Okay, sounds great. Thank you. Thank you again, Dr. Del Castillo. I really appreciate it. And, you know, there's another gentleman that's here today, and I obviously have to respect privacy, but there is somebody here that had a heart transplant with scleroderma. And so, yes, and somebody that's become a dear friend to me, and proud to know him. And it's just these moments that you guys set the examples for other people, that nothing can stop you. there is life after being diagnosed with scleroderma, even during these extreme moments, that there still is life after scleroderma.
Yeah.
So again, thank you very much. So some of these questions, Dr. Del Castillo, are, I want to say maybe a little bit of a recap. And so I'm going to read them first, okay?
Mhm.
So you mentioned toothpaste, correct? Can you just quickly confirm what those were? What were the good toothpaste that you would say somebody with scleroderma should use? And mouthwash
Yes,
for dry mouth?
any type of toothpaste that has fluoride in it. I like the Colgate Total. The regular Colgate Total, not necessarily the whitening, although the whitening is going to have fluoride too, but the Total is more of a whole package type of thing, you know.
Okay, and the mouthwash, is that the same?
Any mouthwash that has fluoride in it.
Okay,
And
but
doesn't matter
also
the brand.
for the dry mouth, because I know, for instance, they were prescribing, giving Biotine, and when I worked at UCLA, they used to give it out as samples all the time. But I know that there's been a couple others, I think, these days. Do you have any thoughts on that?
Biotine is usually the one that that the people usually get. There's another one. If you give me 1 second, I can
Yeah,
find it. See.
Andrew, don't we have that in the office?
We do have some in the office. I'm not in the office, so I don't know what it's called. We were just showing it yesterday.
Yeah. Right before the pandemic, they donated it to us, and we were going to go to the support groups and do a talk, and then we had the shutdown.
Okay.
Somebody's saying Spry, S-P-R-Y.
S-P-R-Y, that's Spry is a xylitol chewing gum.
Okay.
Yeah, that's good. That's good. That's comparable to the ice cubes that I showed you. But yeah, Spry is fine.
And the other thing, like before, if we miss something, I'm sure that we can always send a question to Dr. Del Castillo that he can answer for us.
Absolutely, absolutely.
Yeah. Okay. What about foods that you would think somebody should stay away from?
It depends on. You're talking about the in terms of dental, right?
Yeah.
Anything sugary or like chewing, like Swedish fish or you know, those kind of like gummy bears, that type of candy, even caramel too. Anything that is really sticky that can get stuck to your teeth and may get stuck in between, you know, in the areas in between the teeth, that is going to be very difficult to remove.
Okay.
I would say stay away from those.
Thank you. Somebody was talking about my mouth shrunk, and because of that, my teeth have been pushed together. Would a product like Invisalign work for someone like me?
It could because Invisalign, the way Invisalign works is by expanding the arch. So, but then we have to look at the bone level of the teeth, because if the teeth have very little bone level holding them, you can push them back, but probably the forces of the cheek and the tightness of the cheek is going to push them back again in the position they were previously. And relapse is very common with braces too, with any type of orthodontic movement. So you get braces and your teeth are all straight, but you have to wear a retainer to keep them in position. If not, they're going to start going back to the previous position too.
Yeah.
But it is an option. It is an option, but it has to be evaluated carefully to know that, you know, there's enough bone support holding the teeth. The other thing is that to do Invisalign, you need to take an impression of the mouth. Nowadays, we do a scan, also a digital scan. I also have a scanner in my office too, and most of the dental office right now have scanners. But the thing is that if your mouth is, if you have a small mouth opening and you're going to use a scanner, the scanner is actually quite large too. So it may be difficult to capture all of your teeth if you cannot open the mouth too much, because it's a rather large device. So, and then taking an impression with a small mouth opening can be also a little bit tricky. So, I mean, it's certainly an option doing Invisalign, but you have to consider, you know, all the variables before deciding to go that way.
Yeah, because isn't it often that the teeth continue to change or move with scleroderma? So if you're doing Invisalign and they're putting your package together, so to speak, how do you keep up with that just in case there could be other changes?
When the way Invisalign works is that you wear clear retainers of your teeth,
Right.
and you change them every 2 weeks. So every retainer moves your teeth a little bit, a little bit, and a little bit. And then when you're done, you're going to wear a retainer that holds them in position.
Okay. Thank you. Can clenching your teeth at night cause nerve damage to the point of causing facial numbness and tingling? She further, let me just finish. She further elaborates that they thought it was a sensitivity to toothpaste, or tried a toothpaste that was for sensitive teeth, and it didn't work. And over the course of the next year, she started experiencing tingling on her face, had many tests, currently tingling and what feels like numbness is located inside of mouth, and tingling is located mainly below eyes and center of face.
Yeah, so these could be symptoms of TMJ from clenching, and if usually I'm not sure if we get a lot of degeneration of the condyles of the TMJ with this disease, but if you get a lot of degeneration in this area of the condyles where the mandible articulates, and you're clenching your teeth, you're putting a lot of pressure in that area too. And there's nerves behind it too. So that creates a lot of pain too. Also, when the teeth come together, you want all the teeth to come together evenly. You don't want one tooth taking the load that everybody else is supposed to get. Or if you're missing teeth too, then you have, we have 4 molars on the top and 4 molars on the bottom. But if you're missing, 2 on one side, 2 on the other, then you're overloading the rest of them. So that could also make things even worse. That's why it's so important to have the back teeth to help. Now, if with those type of symptoms, the best way to go initially would be with a night guard. And a night guard that is not really the over-the-counter ones, but one that is made by your dentist. Because the night guard that we can fabricate for you is going to be hard. The ones that you buy over the counter are usually soft. If you put something hard between your teeth, when you close, see what happens normally when you close, there's ligaments that hold the teeth in place. As soon as there's a tooth contact, those ligaments send a signal to the brain, okay, the teeth are closing, you need to close. So when you put something hard between them, that trigger is removed. So that trigger to the brain to close is shut off if you have something hard in your mouth. If you have something soft, that trigger effect's still going on. It's like when you're chewing gum. You put a gum in your mouth and you're chewing. As long as you feel that it's bouncing, you keep chewing on it. So there's the same effect that a soft night guard will do. So a soft night guard is fine for like athletes and stuff like that. But if you're clenching or grinding, a hard night guard is the best way to go. That's gonna, shut off that trigger effect, and it's also gonna relax your muscles too. But at the same time, if you're closing and you're hitting one tooth before the rest of them, that tooth is taking a lot of load. So that pain could be coming from that load, and that has to be adjusted. So even if you have, say you have that condition where one tooth is taking the load of everybody else, and you wear a night guard and you feel fine, but as soon as you take the night guard off, you get that contact again.
Yeah.
So that has to be adjusted so that doesn't happen anymore. And those contacts are usually, the symptoms that you get from them are usually, people usually think that it's a root canal thing. And sometimes, people that have TMJ problems end up getting root canals on all the teeth, and the problem is still going on because it can be misdiagnosed as a root canal condition.
So, but perhaps though, the night guard, from what you're saying, maybe this person or others will not feel as much of the tingling and everything because it's taking some of that pressure, that load off, if it's the tooth versus something else. Either way, it's helpful.
It's helpful, yes.
Yeah.
And absolutely. And especially this time, like nowadays, with everything that is going on, people are really stressed. So that also is a big factor to consider. When the lockdown happened here in Boston, I don't know how many patients I had calling with emergencies with broken teeth of how much they were clenching.
Wow. That just dawned on me what you're actually saying. I think that's probably the majority of us, scleroderma or not.
Yeah, exactly.
Me. Another question. Doctor says I have Sjogren's, but my mouth is very dry. Does not. Doctor says I do not have Sjogren's, but my mouth is very dry to the point of not wanting to eat solid foods. I've lost over 35 pounds in 6 months just from not feeling like eating because of the difficulty due to dry mouth. I've tried a couple mouthwashes, but they seem to make the feeling of dryness feel worse. Dentist said teeth and gums are still okay though. So this person's a little confused on what the message is. What do you say?
Well, it may be, I mean, I don't know how long this has been going on for this person, but it sounds like maybe a candidate for a medical, like medicine, medications to induce saliva production. The one we mentioned, but that's something that has to be, discussed with this person's physician.
Right.
But
because they're saying that they don't say that they have Sjogren's, which we usually know plays a huge role. So I think it's very confusing to this person.
Another thing could be the medications too that this person is taking could be causing the dry mouth too.
Okay. Do you, somebody was mentioning about some of the therapies that might be more natural. Do you have any thoughts on any natural therapies for things like mouth sores, bacteria, gum recession disease, acid erosion, even teeth cleaning products?
That's a good question. Not really. I mean, I have patients that use there's a brand from Vermont, from Maine or Vermont here, that have all these natural components, so like health losing the word, health products that are all natural based. Tums is a brand, actually. Tums. I don't know if you have it there too.
Sounds familiar.
Yeah, it's fine. I mean, I don't see any problems with going that way. In terms of any type of dental condition,
Okay, thank you.
Welcome.
Okay, Jan, I see your hands up, but I'm going to go through the questions first that we have on the board. Let's see here. There's a lot of really sweet comments for you, and I'm gonna, when we're done with all this, I'm gonna copy them and I'm gonna send you an email so you can see them, okay?
Thank you.
Let's see. Question. Just a doctor think. My dentist forgets about me for too long, so going to a private dentist there, and they said that there was a treatment they put on his teeth to protect the enamel. He said, but it cost actually a few thousand, they're saying. He says he doesn't remember the name. What do you think about something that protects the enamel? Do you know what he's talking about? And if so, is it something that's that expensive?
To protect the enamel, I mean, what I can think of is a fluoride, varnish that the picture I showed. But maybe this person needs, caps on all the teeth. That would cost thousands, but not a fluoride application.
Yeah.
So it's hard to say,
Okay. What are your thoughts on water pick? My dental hygienist recommended this, and I have found it more effective to dislodge food particles. I also put a few clove oil drops as antibacterial.
Yeah, that's fantastic. That's fantastic. Yeah, water pick works really well too.
Good to know. Yeah, I hear that a lot from the dentists these days. Your thoughts on oil pulling with coconut oil, chewable oral probiotics that increase good salivary bacteria to help prevent oral decay.
Yes, absolutely. Yeah.
All right.
Yeah.
Wanda, you're on a roll. Okay, let's see.
Good, Wanda.
Let's see. Let me keep going down here. Let's see. Somebody's talking about a bad experience, which I know that this happens a lot, especially with the small mouths, that they had a bunch of teeth that needed to be taken out in the back, 5 to be exact, and they were very rough. They weren't very caring, and he ended up in a lot of pain and a lot of rips trying to keep the mouth open, and it was a very bad experience. So it was more of a sharing of a bad experience, and this is something why a lot of people with scleroderma get disheartened about going to the dentist when they don't know, and they're this rough with a patient with a small opening.
Yeah.
Let's see. I have a water ionizer machine that makes alkaline water. Would it be advantageous to brush my teeth and rinse with alkaline water?
Yeah.
Really?
That makes sense. Yeah.
Good to know. Okay.
Another one that.
Let's see. Is there a way to slow down or halt gum recession?
Yes, but the way to do it is by regular follow-ups and regular cleanings.
That kind of follows into the next message, which my insurance doesn't cover for more frequent than every 6-month dental hygiene appointments. Is there a way that they can get authorization for more frequent visits with my scleroderma diagnosis? Do you think that would warrant it?
Yes, that's probably going to be something that the dentist is going to have to work out with the insurance company. I don't know if they put it through through a medical.
Yeah.
Okay. Thing, maybe, but if not, then maybe this person can work something out with the dentist, like get the 2 cleanings that the insurance covers first, and then maybe the other 2, I don't know, half price, or work something out with the dentist.
Yeah.
Another one that.
Plus we know that we have all insurance cover things different, and I know that some are better with prior authorization for things than others, so that's probably easier said than done. And I know a lot of people, even myself, have to pay out of pocket if I want any extra cleaning. But
that's very, very common. Yeah, that's very common.
Maybe with the diagnosis it might help. Let's see. Yeah, others are saying the same. I can only get a cleaning once a year as well due to disability. I'm in the process. She's kind of talking about seeing if she can get this covered, and that her mom was able to with diabetes. Wanda, you're our star today. So she's trying to see if she can get an approval for every 3 months. Maybe you could keep us abreast of that, Wanda, and I can share what you did with others. Okay. Well, it's funny. How do we find a dentist who is more patient and trained with scleroderma? Thinking of seriously switching my dentist. And before you say something, Dr. Del Castillo, I think we go back to having a very candid conversation with the dentist, asking them if they might want to watch your video. And because I think that would be very helpful for them to be a little bit more understanding. But we do know it's easier said than done sometimes. And the other thing would be for people to send us where you live, and let's see if Dr. Del Castillo might have some colleagues in your area. You never know who he's mentored that has gone out in different places. California is just one of them, and he's already given me one name, which I'll be sharing with my support groups. But there could be an opportunity for others to have the same information. And then I'll let you elaborate more.
Yeah, and both me and Dr. Leader be happy to not really coach the dentist, because I mean, we're not gonna tell them what to do, but we can discuss the case together and give our point of view, or our way that we would approach the case type of thing, So it's
That's
not
nice.
that we're imposing, like, you don't know what you're doing, let me show you. No.
Well, that's the problem. It's called chip on the shoulder sometimes. With some of them, they don't want to hear it, but you do have others that are a little bit more open. So just knowing that people could approach you and maybe send you an email and say, would you be willing to talk to my dentist? And maybe the dentist would even talk to you by phone, so that would be something that's acceptable for you, Dr.
Yeah, absolutely.
Okay, thank you. Let's see what else. Just another one saying would love more info on gum disease and recession. Do you have any more thoughts on that?
The best person to see with gum recession, like any gum disease, is a periodontist, which is the specialty that deals with these conditions. And like I said, the way to stop it and so that it doesn't progress further, regular checkups, regular cleanings, home care too.
Yeah. Okay.
But this is something that happens to everybody, not necessarily scleroderma patients. It happens to everybody, and it happens with age too. So
yeah,
Okay, I have another question. Since I have scleroderma, my teeth have become very discolored. I've tried bleaching once, but it was very painful and didn't have any effect. Do you have any advice?
So no changes with, well, an office bleaching could be an option. The thing with an office bleaching is that it can cause sensitivity too. And also it works, whitening, either office or over the counter whitening works as long as you don't have too many fillings on your front teeth. Okay. Because if you have fillings on your front teeth and you do a whitening, the part of the tooth is what's going to whiten, not the filling. So that may show as a dark tooth, but what is showing dark is actually the filling and not the tooth. You know what I'm saying?
Mm-hmm. So if he says that he did bleaching from home, and it was, well, I'm actually assuming that, and I could be wrong. When you get it done at the dentist, is it more stronger and you get more of a better outcome once versus maybe several times in these home kits?
Exactly. Yeah.
Okay.
Exactly.
Okay. Thank you. There was a question. What is the name of the IV med for Raynaud's that you received in the hospital?
Oh, when I put the picture, I try my hard to find the name of it. I can't remember.
Really?
But
was it Iloprost by any chance?
I can't remember, Tina.
Okay. Maybe we can revisit that, right?
Yeah,
Okay.
I'll see if I can find out, because the doctor who put me on that medication, I'm not seeing him anymore, but I have contact with him. I could ask him again. Okay. Or I can get into the portal, the hospital portal, which has all the information. I may be able to find what they did, and I can send you the information.
Great.
The other thing is that I'm taking right now. See, I don't have any ulcers right now.
And you're in Boston.
I'm taking amlodipine.
Uh-huh.
I'm taking oh my God, I'm forgetting the names of the medication. Give me 1 second because I have it here.
That's okay. I'm going to look for another question while you do that.
Sure. I mean, I take it every day and I'm forgetting.
That's okay. We can always add that later too. So Wanda wanted to say, she Google oil pulling on Pinterest. Since I've been doing it nearly daily, no cavities, and it helped my gingivitis tremendously. I used unrefined organic coconut oil and put clove oil drops in it. So that's just an FYI for everybody.
Oil pulling, I'm writing it down. Okay, thank you, Wanda.
And while this isn't part of this was more about your story, clarification, what was your DLCO? She thought it was, did you say 1.82, which it must be the
FVC,
that's what I thought.
Volume capacity, yeah. 186.
Okay.
And right now I'm 3.8.
Thank you. Yeah, because that didn't make sense for a DLCO.
Yeah, sildenafil is the other one. So the medications that I take for the Raynaud's and for the ulcers, sildenafil and amlodipine. And I have no ulcers. I haven't had any ulcers in since after the transplant.
Great. There's so many wonderful comments. I love it. Just as I'm reading them, I can't wait to share them with you. Let's see. I think we can go to Jan, but give me 1 second. Somebody else said that they had the soft night guard and that they woke up with it on the floor. They spit it out. Oh, and Eva says that her mouth guard was custom by the doctor and it stopped her clenching and grinding. Yep. And what about the 3-finger rule? Should the fingers be positioned on a horizontal or vertical way?
Yeah. So see, I can get about 2.5.
Okay. Uh-huh. you know, one of our talks from Dr. Sizemore, he talked about putting, you know, the tongue depressors when you're at the doctor, filling them up and seeing how much you can keep adding to tighten. And we have them actually filmed. Yeah, that you can go to our website and see that. I use Thieves essential oil for cold sores, canker sores, and diluted with water as a cold spray. That's to everybody if somebody didn't hear that. Here's one saying that she gets her cleanings every 4 months. Insurance pays for 2. I pay for the 3rd one. Dentist is very kind and gives me a discount for the one I pay for. Always ask. Great information. Exactly. Thank you, Leslie. Let's see. Yeah, and it says, does Dr. Del Castillo offer consulting service with my dentist for treating scleroderma patients? And then said his niece has scleroderma. Interesting. Leslie, I'll provide an introduction to you after to Dr. Del Castillo, and you guys can communicate directly, okay? And let's see. I've been advised with implants, be very careful as bone structure changes. About implants, what are your thoughts about? I'm going to ask the question. What I think he's trying to say is your thoughts, because he says with the changes with your bone and maybe even the changes, you know, with scleroderma and the tightening, even in the gums, what are your thoughts on implants?
As long as there's enough bone to place them in the proper position, it's fine. And once you have the implant in, that's going to prevent further bone loss, as long as it's maintained. Because the implant is inside the bone, surrounded by bone. So and every time you chew, you induce, you keep that bone alive. If you get what I'm saying. So having the implant there functioning is a good thing.
Okay, thank you. If you need a crown, is it best to have gold, porcelain, or zirconia? Given a choice, I usually choose zirconia. What's your thought?
Gold, zirconia, or porcelain. It depends on the tooth, on which tooth we're talking about. And I mean, if you want to have a front tooth in gold, that's fine. But usually the further back you go in the mouth, the less space there's available too. So I cannot make a very thick crown on a second molar. I will have to take down the tooth too much to have enough thickness for the material. So usually for a back molar, like way in the back, we usually go for gold or zirconia. Zirconia is a tooth color material, and it can be you can have it in very thin, thin areas, and it's not going to break, or it usually doesn't break. I'm not going to say that it doesn't break, but it usually doesn't break. But way back in time, we used to use gold all the time, especially for the back molars. Because for gold, I don't need to reduce it too much. Gold doesn't break, so it usually lasts a long time. But with the prices of gold nowadays, it makes it almost impossible to do gold. So we're doing mostly porcelain and zirconia. So it actually depends on which tooth we're talking about. The new porcelains that we're using right now are very, very good. The problem with porcelain is that it can fracture. So zirconia is similar to porcelain, but it doesn't fracture as much. But again, it depends on which tooth we're talking about. I would say, it doesn't really matter. Either, porcelain, zirconia, or gold, they all work really well.
Thank you. Jan, I'm going to go ahead and let you ask your question. Go ahead and unmute.
My question is, I have extremely bad allergies to medications. I lost 2 crowns in the back, which had root canals where the teeth completely broke off. And this was just prior to the shutdown, and they wanted me to have both of the roots extracted.
Yeah.
But because of my extreme allergies to anesthesia, sedation, I mean, I'm puking for 6 hours. They can't stop it. I didn't get it done for those 2 reasons, because of the shutdown and because I couldn't seem to get through to the oral surgeon, what my problems were. He didn't really want it. He kept saying, oh, don't worry about it, it'll be fine. So I don't know where to go with this. It's been a year now, and
And all the medication, like all the anesthesias give you the same type of symptoms?
You know what? There's only one, believe it or not, it's the one that killed Michael Jackson. Is propofol is the only one, but they're saying they can't use that. So
yeah, that's I would say it's kind of dangerous to use it for.
Yeah.
I
mean, I go to Stanford, but they don't have a dentistry department, and they have trouble with me. They don't even like me to undergo any procedures anymore because they can't stop the vomiting.
And when it happens, how long does it happen for then?
It can go about 5 to 6 hours. They're literally kicking me out of the procedure rooms, and they're like, well, okay, you know, it's 5:30 now. So it's a huge problem. I just have these horrible, and it's gotten worse over the years. It used to be just a couple of you know, whether like might have been fentanyl at one, you know, then it was midazolam, and it just now it's snowballed. And on top of that, food allergies. It's just so bad.
Regular dental anesthesia, like local anesthesia, still give you the same.
Yes. Yeah. Even when they, I just had a procedure done, celiac plexus block, and I think that, yeah, the celiac plexus, and I was extremely ill for hours. Even colonoscopies, endoscopy, it's terrible. Terrible.
And it's all because of scleroderma?
They think that, well, my rheumatologist thinks that, she said she sees this with some scleroderma patients develop a lot of sensitivities, and some can just get off the charts, and I guess I'm one of them. Lucky me, yay.
Wow, yeah, no, I mean, I don't know, Jen.
I was thinking of going to UCSF, you know, because they have a dental place, but I don't know. I'm just wondering.
I think that's probably going to be
where I can get a list of dentists that maybe have dealt with this, that deal with scleroderma patients with these extreme sensitivities to painkillers, sedation, etc.
Yeah, Jan, I was also going to mention, you know, I know that with, you know, places like UCLA School of Dentistry, but any place that's a School of Dentistry might be a place that you want to check, but you are a unique and probably very difficult for most. And I feel for you. And I know that Dr. Del Castillo does as well, because it's even, you know, he's having a hard time thinking of what could be the best way. But I think a place that's up on the latest, and always the places that are teaching facilities are probably helpful. Would you agree with that, Dr. Del Castillo?
Yeah, I think so. I think so too. And usually the dental schools have the medical really close by, so they can work together in treating you.
Yeah.
Yeah, I think that would be the best option for you, Jen.
So like maybe like UCSF, or if I go down to visit family, UCLA, you know.
Yeah.
Yeah.
Okay. Thank you, Dr. Del Castillo.
Welcome.
Yeah. Sorry, Jan, that you're going through so much.
Thank you.
Sorry.
There's a gentleman that says, I have no dental insurance. Any suggestions? He's 80 and has been using pulling to keep infection under control. My teeth do not bleed and tartar is under control. He's telling others that they might want to try that they're having problems too, which I guess he's trying to do the best he can without the dental. Do you have any suggestions on that? I'm thinking
again, a dental school is probably going to be the best option, because in the dental school, the prices are usually a lot less than will be on a private dentist. These are students that are becoming dentists, but everything is supervised by the faculty. So there's not that they're working on their own. Everything is supervised and a much lower price.
Yeah, agree. And
plus I know that there's all the knowledge there too. So.
Yeah. And you might want to call your closest, school of dentistry, depending on where you live, because I know that there's even a specialist that might even be the head of the school of dentistry with Sjogren's that we met at one of the walks. And I don't know why his name is escaping me, but I'll put it in my follow-up email to everybody when we send out the link to Dr. Del Castillo's recording. But yeah, I think we're on the same page with that, right?
Yeah, the dental schools have usually a pathology department, and they deal with the Sjogren patients too. So yeah.
Thank you. Let me see if we've got anything else here before we go. People are bringing up a lot of stuff about Raynaud's, but we've really run out of time, and I can't really go over those things. I think we just need to stick with the task at hand. And if there are helpful things in here, I will copy and paste them into your email, guys. because everybody's giving some really great, and this is what I love about support groups. And I want you all to remember that. That's what our support groups are for us to share, you know, our best practices, so to speak, of things that are helpful for us, as well as these moments where we just need support from our friends or learn from each other and become friends. Maybe you've never been to a support group before, but these are very seasoned. I always take pride in that our patients, our families know so much about scleroderma compared to other conditions. So just a thought for everybody that if you haven't been to a support group meeting, come and learn from others. I think that's it. I just have a lot of thank yous for you. A lot.
Yeah.
So I think
thank
that
you, Doctor, this was great. And thank you everyone sharing this information and hearing from everyone helping is just, this is what we're here for. And so what a great topic and what a great group.
absolutely. Thank you, Andrew. And thank you, Dr. Del Castillo. Thank you everybody for staying. This was a long day, but we think it was really important. And again, just to reiterate, I'm going to send everything with you all. I'm going to take all these great suggestions and put them in my recap email. So everybody has everybody's advice. Okay. And I guess
you're incredible. Thank you so much.
oh,
Very
that's
welcome.
sweet.
Very welcome.
Okay. Well, I think that we're going to end, everybody. So let's all say goodbye. Thank you so much again, everybody, for coming, and enjoy the rest of your weekend. Thank you, Dr. Del Castillo. And
My
thank your
pleasure.
family
My
for
pleasure.
lending you to us. Okay.